Good afternoon and welcome to the kickoff presentation of the 2020 VHHA Lunch and Learn webinar series. This webinar series will focus on quality, patient safety, and high reliability in healthcare facilities around Virginia. My name is Christy Burnett, and I am the Director of Patient Safety and Quality in the VHHA Center for Healthcare Excellence. I am your moderator for today's presentation. Before we get started, there are a few housekeeping items I'd like to go over with you. This webinar is being recorded. All participants are muted. Questions and comments can be addressed at the end of the presentation, and you'll find an area to enter those questions on your control panel. There'll be a short feedback survey that will launch at the completion of the webinar, and this series does only require a one-time registration. I would now like to introduce our presenter for today. Welcome to Dr. Galicia-Castillo with the Glennon Center for Geriatrics and Gerontology at Eastern Virginia Medical School. She completed her medical school internal medicine residency and geriatrics fellowship training at EVMS and joined faculty in 2001. She is currently the Sue Faulkner Scribner Professor of Geriatrics and holds board certification in internal medicine, geriatrics, hospice, and palliative medicine. As part of the Geriatric Academic Career Award Program, she earned her Master's in Education from Old Dominion University in 2005. Dr. Galicia-Castillo's honors include the John A. Hartford Geriatric Leadership Scholars Award from 2007 to 2009, and she has been a member of the Alpha Omega Alpha Medical Honor Society since 2007. And she has been recently recognized by the Coastal Virginia as a top doc in both geriatrics and palliative medicine. Dr. Galicia-Castillo currently serves as the section head for palliative medicine, as well as the fellowship director in hospice and palliative medicine, which recently started their first fellow in July. She is the medical director for Centera Norfolk General Palliative Medicine Team and Lake Taylor Transitional Care Hospital Supportive Care Medicine Team. Dr. Galicia-Castillo research interests focus on palliative medicine and education. Welcome to Dr. Galicia-Castillo. The floor is now yours.
Thank you so much for that kind introduction, Christy, and hello to everyone that's out there. Usually I like to have interactive discussions in this world of COVID-19. It's a little bit different, but I believe there is that chat mode that's available there. So if you have questions, please, or comments, please type into that area. So thanks again for allowing us the opportunity to talk about our supportive care medicine service at Lake Taylor Transitional Care Hospital. And this is going to really be an overview of what we've done with the program, and would love to have questions and answers for further discussion afterwards. So just in general, just a brief description of what Lake Taylor Transitional Care Hospital is. It is a freestanding long-term acute care hospital. We have 296 beds. Of those almost 300 beds, there are 104 that are hospital level. Of those 104, there is a pediatric wing as well, where there are 25 beds. And our hospital levels located on the second and third floor. On the first floor, we do have intermediate care, long-term care, as well as skilled nursing beds, 60 that are long-term care and 132 that, as you can see there, are skilled beds. Mr. Tom Orsini has been spearheading and leading the facility since, I believe, 1996. And the hospital in itself has a very interesting history, which will actually, it comes back around, and you'll hear how that history actually has really contributed to our fellowship. So next slide, please. In terms of the history, Lake Taylor's been around for quite a while. It actually, I want to say it was in the 1800s or so. Mr. Orsini always has a great story behind the facility, but it was an almshouse for many years. It was a place where nobody wanted to go, where people went to go and die, and over the years has really changed that to becoming one of the premier rehab facilities and long-term acute care facility in this area. Within its history, though, it did serve as an almshouse, as I mentioned, but it also later served as a TB sanatorium. And this is Dr. Brock, Dr. Fosque Brock, who actually served as a physician that worked here at Lake Taylor. And as part of his family, I believe the family lived on site, and his son, Macon Brock, grew up in that area. And later down the line, Miss Joan and Mr. Macon Brock gave us a very generous gift that allowed us to help establish the supportive care medicine team at Lake Taylor in honor of their father. And it's just very interesting to hear the history. So they support the fellowship as well as the actual program at Lake Taylor. If you could go to the next slide, please. So when we started this program, we needed to start with what was our mission statement. What were we going to do there at Lake Taylor? And we are talking about palliative medicine, but our team is called the Supportive Care Medicine Team. And we can talk a little bit more about that in a few. But our team is dedicated to improving quality of life and the experience for those who are living with serious illness through a very interdisciplinary approach. We educate and we collaborate with our healthcare professional colleagues, really with the goal to provide the best possible patient and family-centered care for those that we serve. If you can go to the next slide, please. In terms of the history of the program, we started in January of 2018. At that point, we had 0.2 FTE of a physician. That was myself. I was going there for a half day on Mondays and Thursdays, kind of putting the program together, getting some education up and running, and doing in-services. And luckily and fortunately, in July 2018, we were able to recruit a nurse practitioner who was 0.4 FTE, and she is there Mondays and Thursdays for the full days. And we worked together with her and the team, and the next step was getting our clinical program up, but then the next step was getting our educational program up with our hospice and palliative medicine fellow, who was able to join us last year, July 2019, and he is our first fellow in our program. We are supported 0.2 FTE there at Lake Taylor, so our fellow spends a half day Mondays and Thursdays with me there as part of his long-term care experience. You can go to the next slide. And this is part of our team. As I mentioned, we have all different levels, not just the LTAC level, but also long-term care as well as skilled care. Who we have pictured here is the hospital level. I wasn't able to get our first floor team on, but that's myself, along with Dr. McQuain, who is our fellow. We also have the core team, who is actually there at Lake Taylor. Minnie Gardner, who's our social worker. We have our nurse managers, Andrea Franco and Stacy Kilgore, from the nursing side. Our chaplains is Victor Phillip, who's there at Lake Taylor as well. Linda Christie is our nurse practitioner, with whom I've worked with in the acute care hospital over at Norfolk General, and transitioned over to Lake Taylor. And we also have admin support and representation with Dr. Patty McDougall, who is the VP for Patient Services. Who we don't have pictured is Tiara Wright, who is our social worker on the first floor, as well as Wanda Steffens, who's our nurse manager and manages all of the units on the first floor. Go to the next slide, please. So just to go over the process of how our service works, we start off with, we have to, as in the acute care hospital, we need to have a consult before we see the patients. The consults come either from the attending physician or the team. Then the consult is then processed over to our team, and they are seen by either myself or our nurse practitioner. For those patients who do not have decision-making capacity, contact is made with the patient's medical power of attorney and focuses on clarifying goals of care. During this process, our chaplain is also there to help support if the patient is able to take on that role. The attending, once we do meet with the patients or their family or medical powers of attorney, and we usually will have a meeting to clarify what's going on with them, what are their goals. At that point, once we've completed that process, I'll keep the attending physicians updated with any changes. And throughout this whole process, we do have our multidisciplinary team, as we had shown earlier, with whom we meet weekly to discuss all of the patients on the service. So we are looking at all aspects from, again, the social work side, nursing side, medical side, and spiritual side as well. Go to the next slide, please. So in terms of who we've seen so far, I'm just going to give you an overview of the residents that we have seen. We've had 143 consults to date. I think actually we've received a couple of new ones today. Age range is very interesting. Actually, my background is in geriatrics, so I tried to stay away from kids, but we do have a pediatric unit there, and we have most recently had babies 3 months up to 101 years old. So really the whole spectrum. In terms of the patients, it's kind of a split between males and females. In terms of ethnicity, it's about split, half African American, half Caucasian, and then kind of other as defined. So next slide, please. In terms of sites of service, we really had focused a lot on our second and third floor, which is our hospital level, but we again have expanded that, and that also includes our long-term care and our skilled, who are located on Beechwood, Camellia, and Dogwood. And next slide. In terms of diagnoses, it's a little bit different, as these folks are coming from the acute care hospital, coming here for long-term acute care. So we do have quite a few who have anoxic brain injury, persistent vegetative state, so some of the neurologic diagnoses, end-stage renal disease. On the second and third floor, there is on-site dialysis, ALS, COPD, cerebral palsy. That's mostly from our pediatric unit. And some of the folks from the pediatric unit are actually adults, but because they've been there for such a long time, they still stay in that unit to maintain consistency for them. Next slide, please. Devices in terms of tracheostomies and ventilators and pegs. Again, in our hospital unit, that we certainly have those folks there. In our long-term care, we don't have those devices, as you can see, just a wide spectrum of different patient types. And you can go to the next slide, please. This, I thought, was surprising. So in terms of advanced care plans, for those, we have about 42% of the patients that we've seen do have advanced care plans, which is surprising because in the community, I think it's about 20% of folks who have advanced care plans. So that was good to see. And some of them we have actually, if they're able, we help them complete those advanced care plans if they have capacity. Go to the next slide. In terms of code status, that is one of the things we talk about in terms of goals of care, and many come in as full code. As you can see in the blue, that is before consultation, and in the red, it's after. With discussion of goals of care, several of them do change to be allowed a natural death whenever that occurs, and for some, they move to comfort measures. Next slide. In terms of disposition, many of them stay at Lake Taylor. A third of them do die, and we'll talk a little bit about that. As you can see, some transfer to other facilities, and a small percentage do go back home. Next slide. And this is a piece that I think is very helpful to us, and I think helps define the success. We allow folks, because some of these people, this is home for them, and this allows folks to, when death occurs, be in their home. And as you can see here, of those, the third that do die, majority of them do stay at Lake Taylor rather than getting transferred out to the acute care hospital. Next slide, please. I do want to just point out this study that was done by Macomb and et al. That was just published in the Journal of American Geriatrics last year, I think late last year. There really has not been a whole lot of research looking at long-term acute care hospitals, and this is the first study that has really looked at this setting. And the study, let me just see the number of folks they looked at. They looked at Medicare data, and they looked at almost 14,000 hospitalized older adults who went on to an LTAC setting. And this graph they show is quite interesting because really there's no data looking at prognosis or what happens to folks once they move on to an LTAC setting. And looking here, you can see that the different colors, the orange is LTAC, yellow is the SNF, red is the hospital, purple is hospice, and black is death. And you can see that within a year, many of the folks do pass away after a year. What I find very interesting is the way it's color coded. So each of these lines are patients going down on the left side on the y-axis, and then the x-axis is time. And you can see people that come out of the LTAC, what happens to them, just kind of with this picture. And you see, again, a little bit more than half die at a year. And unfortunately, not too many get home. There is those few at the bottom. But what I thought was just interesting is just all the transitions, the orange to the yellow to the red and back to orange. And really understanding what happens to folks when they go to an LTAC. And I think this study helps to kind of show what happens to some degree, but there's still so much research that needs to happen. And the piece that I thought was the most interesting, that all those people who with all those transitions, only 1% received the palliative medicine consultation prior to their admission to the LTAC, which is, I thought, was just fascinating, because these are people who all have serious illness, and there was no real consultation talking about goals of care, only 1%. If you can go to the next slide, I think this may help explain that. There's just simply a shortage of palliative medicine providers. In the dark here, you see this is the physician workforce in palliative care. This doesn't include nurse practitioners, social workers. I think it's still low as well. But look at the gray, the lighter gray. These are the patients that would be eligible for palliative medicine services. And there's such a huge gap, and I think that's one of the issues that we see in that last study I mentioned. There just are not enough. There's not enough resources, and we've been very fortunate to be able to have our program there at Lake Taylor. You can go to the next slide, please. As with any palliative medicine program, there are challenges, and we do our best to make it work. The challenges really are the same challenges we see in the acute care hospital. I think our major challenge is the misconception that palliative medicine is end-of-life care, and that's all that we do. And that's something that becomes a barrier for our provider, for the referring providers, as well as the patients and families, because they'll see palliative medicine and they think, oh, I'm not dying yet. But our main goal really is to help people through their journey to really focus on quality of life, symptom management, and those are the big things we really want to focus on, because people in the LTAC, as well as our long-term care, as well as skilled, it's a journey. It's not just one period of time, and our conversations aren't just a one and done. that's the start of a conversation and helping them as they go through whatever process that they're going to go to. And then LTAC, oftentimes they stay with us for months, and sometimes that's where they end up living the rest of their lives. For some, it's transitions back home, which may, because they are so ill, may result in another transition to the hospital again. And being there so that we understand what their goals and values are, what is important to them, so that we can match up what we can do medically. It's just interesting. One of our new patients, we were just consulted on. As we were looking back in the records, I actually saw that patient back in 2012 in the acute care hospital at Norfolk General. So really trying to get past that whole palliative medicine is end of life. That was one of the reasons we changed our name to supportive care medicine within the facility, because many of the patients that may have had a palliative medicine consult in the hospitals, sometimes it becomes an adversarial relationship, and we wanted to get that away, take that away as a barrier, just our name. So our name is what we do. We try to support these patients and families as they go through. And I think is that our last slide? I believe that's our last slide. So I welcome any questions or comments. We'd love to hear what you all have in your facilities.
Great, thank you so much. And while we allow participants to enter any questions, I want to take a minute to thank Dr. Galicia-Castillo for the excellent, informative presentation today, for taking time out of her busy schedule to share the success of their palliative care program, and many thanks. I also would like the participants to know that those slides presented today are available in the handout section of your webinar control panel. And as a reminder, our next webinar in the series will be Tuesday, June 17th at the same time. That presenter will be Diana Willman from Southside Regional Medical Center, and she will discuss their experience with a program to improve medication histories in the ED. I don't see any questions yet. I'll go ahead and leave the platform open. If you want to type in those questions and we don't get to them on today's presentation, we'll be happy to email those responses. This webinar is recorded, so if you know of someone that didn't get an opportunity to listen, we'll have that link available for you. And remember to complete that feedback survey that will launch at the completion of the webinar. And being that I don't see any questions, we'll go ahead and conclude for today. And again, thank you for joining us, and thank you, Dr. Galicia-Castillo, for your help in sharing your experience with us. You all have a good rest of your day, and please stay safe and healthy. Bye-bye.